Let's build that medical brain.
A 52-year-old woman presents with a 6-month history of fatigue and pruritus. She has no significant past medical history and takes no medications. Physical examination reveals mild hepatomegaly without jaundice or stigmata of chronic liver disease. Labs test shows ALT of 74, AST of 68, both of which are slightly elevated. Alkaline phosphatase is 362. The upper limit of normal seems to be 120 on these levels they have given us. Total bilirubin is normal, 0.8 mg per deciliter. ANA is positive and has a speckled pattern. Anti-mitochondrial antibody is negative. Abdominal ultrasound shows no biliary obstruction or liver masses. Given the high clinical suspicion for primary biliary cholangitis, what is the next best diagnostic step? A. Liver biopsy. B. MRI. C. Anti-smooth muscle antibody. And D. Anti-SP100 or anti-GP210 antibody testing. So what we got here is a 52-year-old female who's presenting with vague symptoms of fatigue and pruritus. Now when you look at the physical exam, it is essentially normal apart from some hepatomegaly. Now when you look at the patient's labs, we see that the patient's AST is elevated, ALT is elevated, but only mildly. But what stands out in the labs is the patient's ALP is significantly elevated at 300 plus. Your total bilirubin is normal, your ANA is positive, and an anti-mitochondrial antibody is negative. So based on this picture, a 52-year-old female presenting with these vague symptoms and having pruritus and an elevated ALP, what would you be thinking? You would be thinking something causing a blockage of the biliary tree. Now when you think of blockage of the biliary tree, what should you normally think about? You should think about the most common causes, which is what? It is gallstones. A gallstone can trickle all the way down, cause a blockage in your common bile duct, which we call as choledocholithiasis, and that can cause a problem presenting with pruritus as well as elevated ALP levels. Now they've done an abdominal ultrasound in this patient, and what are they saying? They're saying that they're not seeing any signs of obstruction or masses, so essentially ruling out that possibility. So whenever you have a situation where you think the patient might have some form of gallstone causing a problem, causing a cholestatic pattern, and it turns out to be negative, and it's a female between the age group of 40 to 60, you better start thinking about an important condition which is called a primary biliary cholangitis. Now when it comes to primary biliary cholangitis, typically happens in the 60-year-old female. Now most of the time they will have an autoimmune predilection which predisposes them to developing this condition. Now apart from that, some risk factors can make you at a higher risk of developing primary biliary cholangitis, such as diabetes, such as smoking. Now whenever a patient presents like this and you get all your workup and you're like, I am not seeing a blockage, something's wrong. So when you suspect primary biliary cholangitis, what should be your next step to diagnose the patient primary biliary cholangitis? And the answer is anti-mitochondrial antibody. Anti-mitochondrial antibody is super sensitive. It will be positive 90% of the time. But in this patient, it turned out to be negative. But the patient's ANA was positive. So does this essentially rule out a primary biliary cholangitis? It actually does not. So you still have a 10% chance when the patient will not have anti-mitochondrial antibody positive. So if that is negative, what is your next step? Is it really important for us to diagnose this condition? Absolutely it is. I'll tell you exactly why you need to be diagnosing this patient's condition, and you don't want to miss this diagnosis. So the rightful next step, if your anti-mitochondrial antibody is negative, is going to be two important other antibodies. That is what we call anti-SP100 and anti-GP210 antibodies. These are very unique antibodies that is very specific for primary biliary cholangitis. Now they'll be positive about 30 to 40% of the time. So if your anti-mitochondrial antibody is negative, your very next step should be to pick these antibodies, which is anti-SP100 and GP210. So the answer to this question is answer D. Now, like I always tell you, every wrong answer is a right answer to a different question. So let's look through the other answers to see what we think about it. Well, answer A is a liver biopsy. Does liver biopsy have a role on the context of primary biliary cholangitis? Yes, it does. If your anti-SP100 and GP210 also comes back negative, but you have a high suspicion for primary biliary cholangitis, what is your next step? Then you will go for a liver biopsy, and the liver biopsy can tell you if the patient's got this condition or not. So the next step, if this was negative, would be a liver biopsy. Answer B, MRI. Now would an MRI have any relevance in this condition? It actually would not. An MRI or an MRCP would have more relevance in a close cousin of primary biliary cholangitis, which we call as primary sclerosing cholangitis. Remember, primary sclerosing cholangitis is where you'll see a beaded appearance. So your first diagnostic test in that condition is in fact going to be an MRCP. And answer C is anti-smooth muscle antibodies. Anti-smooth muscle antibodies is for autoimmune hepatitis, not for primary biliary cholangitis. Now that you know the exact step that you need to be picking in the rightful order to diagnose primary biliary cholangitis, why is it so important that we need to diagnose this? Well, what's going to happen if somebody got primary biliary cholangitis? Is there a bad prognosis? Yes, there is. They can end up with liver cirrhosis. So whenever somebody has primary biliary cholangitis, your dreaded complication essentially is going to be liver cirrhosis. And if somebody gets liver cirrhosis, what are they at an increased risk of? Hepatocellular carcinoma. So two bad things can happen in these patients. That is why it is so important for you to really think about this differential and work the right steps and get the diagnosis right. So once you've diagnosed them, how do you treat them? Well, you will start them on a drug we call as ursodeoxycholic acid. Now, what does ursodeoxycholic acid do? The ursodeoxycholic acid, what it does, it basically is going to thin out all your biliary drainage and decrease the blockage that's present in your primary biliary cholangitis. In PBC, what's happening is you have a genetic predisposition, and most patients are prone to getting some other form of autoimmune condition such as Sjogren's syndrome, rheumatoid arthritis, SLE, Hashimoto's thyroiditis, Graves' disease. You will have some other autoimmune condition that makes you prone for it, and now you're going to have autoantibodies against the biliary tract within your intrahepatic area of your liver, and you're going to have destruction of the biliary ducts. And that is the reason for the problem, and that's why you have more of a cholestatic pattern. So once you have cholestatic pattern, all this bile is not draining like it should. So if it's not going to drain like it should, you're going to spill out bile acids. What is that going to cause? It's going to cause pruritus. That's why your patient had pruritus, and the patient is going to have fatigue as well. Whenever you have an obstructive pattern of your biliary tree, may it be extrahepatic or intrahepatic, your ALP will go up. Now, what about the bilirubin? Why was the bilirubin normal? Initially, your bilirubin can be normal because you have not done so much damage. But at later stages of biliary destruction, you can have elevated bilirubin. But initially, expect to only see elevated ALP. Now, all this bile cannot go through because there's a lot of inflammation and the secretions are really thick. So if you use ursodeoxycholic acid, you can thin out these secretions and can improve your biliary flow. So that is going to be your treatment with ursodeoxycholic acid. Now, do you have any other treatments that you can use? Yes, some second line treatments is the use of fibrates on the context of primary biliary cholangitis. Now, I said patients have an increased risk of hepatocellular carcinoma. So do you have to do routine screenings on them? Absolutely. Remember, males, when they have primary biliary cholangitis, are at a higher risk compared to females. So any male with primary biliary cholangitis must get an ultrasound plus minus alpha fetoprotein every 6 months looking for hepatocellular carcinoma. Women, if you develop primary biliary cholangitis and have cirrhosis, then you will do every 6 months ultrasound plus minus alpha fetoprotein. But routine screening must be done. Apart from that, one interesting fact that you also need to understand is decreased response of ursodeoxycholic acid does increase your risk of hepatocellular carcinoma. Not by much, but it still does increase your risk. So the response of a patient to ursodeoxycholic acid can tell you an important story there as well. Okay, you treat the patient with ursodeoxycholic acid. If he or she improves, great. But if they don't improve, what's the eventual solution? If you end up with liver cirrhosis, you might be thinking about liver transplant in these patients as a permanent solution to the problem. So that's primary biliary cholangitis, everything that you need to know. I hope you enjoyed this one. I'll see you on the next one.
Every view builds your brain. Locked in yet? Watch it again.